Dr. Andrea Palmer is an Oklahoma native turned Texan in 2016 when her family moved to Fort Worth. Growing up the granddaughter and niece of surgeons, her decision to become a physician came early in life. Having a wonderful, strong female role models throughout her life has given her passion for working with and caring for women, making obstetrics and gynecology a natural career choice. Dr. Palmer graduated magna cum laude from the University of Oklahoma and attended medical school and residency at OU Health Sciences Center, where she served as chief resident. She practiced in Oklahoma City at Lakeside Women's Hospital for 7 years, where she served as chief of staff before moving to Texas. In Fort Worth, she practices at Phenom Women's Healthcare. So after 15 years of full spectrum practice, Dr. Palmer retired from obstetrics as a quote unquote recovering obstetrician. Her clinical focus is on menopausal medicine and operative gynecology. She has a special interest in robotic surgery and has attended several advanced training programs with the Da Vinci surgical team, surgical system, and Proctor, other surgeons in the technique. She has been privileged to serve as the medical director of surgical services for Andrews Women's Hospital at Baylor All Saints since 2023 and joined the core faculty of their residency program in 2024. She's a passionate advocate for women's reproductive rights, LGBTQIA rights, and physician mental health and wellness. Dr. Palmer has 2 brilliant kids and 2 standard poodles who keep her busy and entertained while not at work. Welcome, Dr. Palmer.
Thank you so much. We have added a kitten to the mix since I think I
Okay,
sent
all
you
right,
all my
update
bio,
that.
so more chaos.
Congratulations.
Thank you. Just bring it on. He's a little love bug. So,
Oh.
good morning, everybody. Thank you all for being here. Thank you for having me. My name, as Petra said, is Andrea Palmer. In addition to all of those things, in my bio that she introduced me as, I am also a widow. I lost my husband, Dr. Blake Palmer, to suicide in 2022. Oh, let's see, how can I advance? There we go. So that's why I'm here. I want to tell you my story. I want you to hear Blake's story. We're going to talk about the risk factors for physician suicide and how, as physicians, we're taught to dissociate and how that can lead to harmful choices. We're going to talk about barriers to mental health treatment and the rates of mental health diagnosis. We're going to talk about some protective factors. How can we protect ourselves against this risk and protect our partners? And some ways to help us access and manage our own emotions. For disclosure, as I mentioned in my bio, I do work with Intuitive as a proctor, and that's my only industry tie. So this is where it all began. Blake and I met the first day of medical school at the University of Oklahoma in 2001. At OU, we were all assigned mods or modules that were basically a homeroom. And for the first years of medical school, we had all of our classes together, we dissected together, we did small group projects together, and Blake and I were what we called mod mates. We made the journey from anatomy dissection partners to study buddies, and then to friends, and then to a couple, which equally delighted and horrified all of our mod mates over the first semester of medical school. They jokingly called our relationship Modcest. And we didn't hashtag back in 2001, but if we did, we undoubtedly would have hashtagged every single photo Mod 230 for life. We were all a really close-knit group. And some of these people in this photo are still my best friends today. We basically knew from the beginning that we would have to work out. We had to spend way too much time together for us not to. And quickly we became inseparable. I couldn't imagine my education, my training, or my life without him in it. We spent our 4 years of medical school together, figuring out who we were and what we were going to be. We graduated in May of 2005 and got married 1 week later. He was my person of the past 2 decades, father to our 2 amazing kids. He was a kick-ass pediatric urologist. He was generous with his time and his energy. He was loyal and protective of anyone he loved, including his friends. He was renowned by his colleagues, and he was a leader not only in his institution of employment, but also in the broader world of pediatric urology. He built a robotic surgery program and a robust pediatric kidney transplant program in Fort Worth. He served on national and international society boards and panels. He was a gifted surgeon, an amazing teacher, and a captivating public speaker. He was well liked by many of those he worked with. He was a good and true friend to many nurses, scrub techs, and hospital staff. His death was a complete shock to everyone who knew him, especially me. Never in a million years, when I woke up on the morning of June 23rd, did I know that my life would change forever. This was us just 2 weeks prior to his death, celebrating our 16th wedding anniversary. I recall that night so clearly. We had so much fun. It was one of those nights when you sit down with your spouse without your kids and you just realize how much you actually really like that person. We remembered our connection. We planned for our future. We talked about the joys of what would be empty nesting and retirement and travel, and how much fun we were going to have doing it all. So let's pause the story for a moment and take a minute to consider the statistics on suicide in our country. National suicide rates hit an all-time high in 2023. I don't have the 2024 numbers, they're not published yet, but I suspect that they will be even higher. We lose roughly one physician every day in this country to suicide. Comparing physicians to the general population, males are 40% more likely to die by suicide, and females are 130% more likely to die by suicide compared to our non-physician cohort. As physicians, we have the highest suicide rate of any occupation, and as we tend to be overachievers in all that we do, we are more likely to complete suicide when you compare us to non-physicians who attempt. And notably, there's emerging evidence of links between areas of specialty and risk of suicide. A review published in 2020 suggested that anesthesiologists, psychiatrists, family practitioners, and surgical specialists might have the highest rates of suicide, but that data I think is still pretty young. When we talk about risk factors for suicide, these apply to physicians and non-physicians alike, but I think as physicians, we have some special things that kind of set us apart from the general population. So when you look at this list of risk factors, mental illness and substance abuse, 90% of physicians who die by suicide have one of those two, if not both, risk factors in their life. Other risk factors, of course, a previous attempt, access to lethal means, lack of adequate support, chronic medical disorders, and hopelessness. So let's look at mental illness. Let's dive in. We consider mental illness in physicians. Over a fourth carry a diagnosis. So this is the amount of people who are diagnosed in the literature. This does not account for the significant yet unknown number who are undiagnosed. These rates are found consistent over several studies and in several countries. And in most surveys, less than half of the physician respondents who reported emotional distress report that they would consider getting diagnosed and treated. I'd like to take a brief moment to talk about ADHD and the spectrum of mental illness. Although ADHD is originally conceptualized as a childhood disorder, research has shown that it persists in up to 60% of adults who experience symptoms as children. Evidence from genetic, neuroimaging, and neurologic studies revealed difficulty in executive functioning in ADHD associated with lack of availability of dopamine and norepinephrine in the prefrontal cortex. The number of physicians out of training with ADHD is really hard to quantify. Self-reported measures range anywhere from like 1 to 24%, but actual data is very limited. I think that this is going to be changing with time. I think if you're in my generation, if you are a, a Gen Xer or a elder millennial, that if you were a well-behaved kid in class, you did not get a diagnosis of ADHD, no matter what happened. And if you got good grades, then they really let you slide. So I believe in my heart that the number of undiagnosed ADHD physicians is probably pretty high. Untreated ADHD can lead to difficulty engaging in effective and efficient study or work, poor academic performance, tardiness or absence from clinical duties due to forgetfulness or disorganization, poor sleep due to inefficient completion of work, poor time management, and baseline sleep difficulties associated with ADHD, relationship difficulties due to inattentive or impulsive symptoms causing conflict or less dedicated free time, secondary anxiety, secondary depression, and increased substance use. So back to Blake, admittedly, he had a history of down moods. He and I would discuss, and I would encourage over the years for him to see somebody, to take something, to talk to someone. He would float in and out of stages where he was down. He was better when he exercised. Um, he loved to train for an event. He loved to do like uh, purposeful things like climb Mount Rainier, do a mud race, run a marathon. And he was better when he exercised regularly, as most of us are. But really, since COVID, he really had not taken the time. He had not prioritized that the few years prior to his death. He was also very likely to qualify for a diagnosis of ADHD. If he had gone to see a primary care physician or heaven forbid a psychiatrist, an astute clinician would have probably recognized this. We joked about it all the time. He was always fidgety, he was always moving, he could hyper focus. When he was alive, I honestly didn't have a full understanding of ADHD and the beast that is poor executive dysfunction. But both of our kids have since been diagnosed and medicated, and the difference in how they feel and how they feel about themselves blows me away. And I have seriously considered that if the TikTok revolution of adult diagnosis of ADHD might have started a few years sooner, that he actually might have agreed to treatment. But getting evaluated and diagnosed and seeing an actual doctor, that would have been a stretch. When we think about substance abuse, which of course itself is a risk factor for attempted and completed suicide, it's also an occupational hazard. I'm going to qualify this whole slide by saying a lecture about substance abuse could be a series that goes on for a year, and I am not going to give it its adequate justice in this talk. Of the many things I'm fortunate for, I'm glad that Blake never dealt with substance abuse, and so this isn't something that I've dived into significantly. But it's prominent. It's so prominent in our profession. Studies vary, but most report rates of up to 20% of physicians have problematic substance issues. 20%. Of note, the overwhelming majority of doctors with substance abuse issues don't feel their use is an issue. Female physicians have higher rate of alcohol abuse than women in the general population. And addiction is prevalent, especially among emergency physicians, psychiatrists, and anesthesiologists. Substance abuse is associated with impulsivity and worsening affective symptoms. It's hardly surprising that physicians with substance use disorders have elevated rates of suicide attempts and completion. Getting treatment for addiction as a physician has its own unique sets of issues going above and beyond the grip of the disease when you talk about licensure and credentialing. And so it is a danger not only in our specialty, but specifically for suicide risk. And this is one of those things that if you see a colleague who's acting erratically or you have concerns about a colleague, going to them is care and compassion. When we look about suicide by the numbers, although a prior attempt is a serious risk factor for death by suicide, as we saw in the original slide, 9 out of 10 people who attempt suicide and survive will actually not go on to die by suicide at a later date. This has been well established in the suicidology literature. Another literature review summarized 90 studies that have followed over time people who have made suicide attempts that resulted in medical care, and about 7% of attempters in that study eventually die by suicide. 23% reattempted non-fatally, and 70% had no further attempts. Most people who died by suicide in the US are not people who have made a previous attempt. Prevention efforts that focus only on those who attempt suicide will miss a majority of the completers. An international review of psychological autopsy studies found that approximately 40% of those dying by suicide had previously attempted, and that was lower among studies of youth. History of previous attempts is lower among those dying by firearm suicide and higher among those dying by overdose. Remembering, of course, that physicians are 2 times more likely to complete suicide, we should really consider that this previous attempt is not, like not having it previously attempted is not inherently protective for physicians. In addition to the risk factors, elevated suicide risk among physicians is likely due to some population-specific factors. We are trained in toxicology. We have readily available access to lethal medications in many cases, depending on your specialty, and additional expertise that can be turned to lethal use. In Texas, we live in a state where you can buy a firearm on a whim. And I've obviously done a lot of reflecting on his life in the weeks, months, and years leading up to his death. And when I think about the day that Blake died, he actually had a cold. He was sick, and he stayed home from work the day that he was sick. And I'll get more into that in a minute. Blake died by self-inflicted gunshot wound. We were not gun owners. There's no waiting period for a firearm in Texas and in most states. And we all know suicidal ideation. If you look at the past slides, people who attempt don't always go on to complete. It's a passing emotion. And so if you look at the evidence on waiting periods for handguns, it is strongly protective for reducing suicide risk. As of January 1st of last year, 6 states and the District of Columbia impose a waiting period to purchase firearms. 4 states impose waiting periods for certain classes. States with permit to purchase kind of impose a de facto waiting period depending on how long it takes to provide a permit. And the length of waiting period varies by state. In California and DC, there's a 10-day waiting period before buyers take possession of new firearms. And in Hawaii, buyers must wait 14 days to receive a permit to purchase. But everywhere that's gray on this map, you can buy a firearm without a waiting period. When we talk about a lack of adequate support as a risk factor for suicide, I think as physicians, again, we have a unique standing with regards to this risk factor. In many institutions, both during and after training, physicians and trainees are encouraged to see their peers more as competition instead of support. Litigation-related or regulatory imposed stress can precipitate depression and occasionally suicide. Stoic training environments normalize stress and distress as inherent or even requisite components of physician identity. Sleep deprivation and long hours are viewed as badges of honor. Asking for help is viewed as weak and is often frowned upon. Blake had a surgical complication the day before he died. Although it was not a lethal complication, it was a morbid one and one that would require significant follow-up surgery to correct. I have no doubt that this plagued him and was a huge factor in his death. He didn't have a mentor or a colleague that he could trust to go to at the event, someone to reassure him that good surgeons have complications and can make mistakes. Of course, I would have told him those things. Over our careers and our marriage, we had supported each other through the ups and downs of clinical practice. But he would always joke that I was legally obligated to love and support him, and so my reassurance meant a lot less than a an outside person. Hopelessness is a feeling or state of despair, a lack of hope. God, such negative, strong emotions. And as physicians, we are not taught, we are not encouraged to attend to and foster our negative emotions. We're taught from medical school onward to compartmentalize, to numb, and to ignore. When we get overcome by our negative emotions, when they finally beat our defenses, we are unpracticed in being with them. And if we don't know what to do with them, it may feel overwhelming. It may feel like they're never going to go away, that they're too big, that they're going to stay forever. They're too all-encompassing. They're too painful to bear. When one cannot see a way out of the despair, dying may seem like a rational solution and one better than facing it. So much of our inability to manage our emotions comes from the fact that we are practiced in avoiding them. We dissociate. And when we dissociate, we fail to integrate our emotions, among other things. In medicine, we often disengage or emotionally constrict or compartmentalize. It allows us to be able to do what we do. It allows us to go to, from coding a patient in one room in the emergency department to popping next door and addressing the ingrown toenail or cough and cold. In OBGYN, we go to one room and deliver an intrauterine fetal demise, and then go to the next room and deliver a healthy term baby. I move in one room from clinic from telling a woman she's got cancer to another woman talking about her hot flashes or having an infertility consult. The way that medicine moves necessitates us being able to do this to some degree. And I remember it being hard when I was a resident, hard to turn off the, or to shut down, my emotions about the tragic event and move on to the other one. But over time it gets easier. We practice it. It becomes force of habit. Several studies show a relationship between increasing dissociation and suicidality. So when we don't know how to handle our emotions and integrate them into our sense of self, dissociation can happen to a detrimental and dangerous level. When we, sorry, when we dissociate, we not only lose our sense of self, but we lose our ties to those who ground us, who love us, and who would miss us when we go. Oh, goodness, this is not what I meant to do. No. So why don't doctors get help? Why does the healer not heal themselves? I think several reasons prevented Blake from seeing somebody about his mood. Number one, he had no time. Number two, he didn't want to have to claim a mental illness on his credentialing forms and licensure applications. He didn't want to admit weakness. And mostly, I don't think he knew how to ask for help. He had no time was both a symptom and a cause of his burnout, and retrospectively, his wildly untreated ADHD. He was chronically behind on charts, like hundreds of charts behind, and the task of getting caught up was always hanging over his head. This turned into long, yet ultimately unproductive work hours. He never felt like he could take time off to go to the dentist or the doctor, much less something as abstract as therapy. The lack of time and chronic feeling of needing to work more caused him to retreat from the things that would make him feel better. Good sleep, exercise, time with family, travel. And I knew he was burned out. Hell, I was burned out. We were all burned out on the tail end of COVID. With Blake, I just made the arrogant assumption that he could keep it up because he had been for all these years. The credentialing form issue is not unique to Blake. I do think this is something that's improving, albeit slowly and ununiformly. This is my recredentialing application at Baylor Hospital in Fort Worth, March of last year. Since your last application, have you been evaluated or treated for a psychiatric or mental disorder which impaired or does impair your behavior, judgment, or ability to practice medicine? Anybody who has had anxiety or depression can say 100% that your behavior and judgment are different when you are in the depths of your disease. Blake was a man of honor. He was a man of his word, and he didn't want to lie. And he thought if he had a diagnosis, he would have to answer yes to this question, and then everything would fall apart. As I said, this isn't unique to Blake. If you're in any physician group on Facebook or in any online forum, you'll see these questions come up all the time. I'm a resident. I'm scared about claiming this. If I get treated, will I have to tell the board? Do I need to claim this on my application? This is a uniform problem. And ultimately, none of us are very good at admitting we have a weakness, especially as surgeons. The high demand, high expectation, actual life or death nature of our work demands perfection, demands our constant availability, demands our holidays, our nights, and our weekends. And except for the early days of the COVID pandemic, we were and are expected to work really no matter how we feel. We're supposed to move on after catastrophic outcomes, going to the next patient like everything is fine. As physicians, we are universally horrible about working sick. I'm usually in a room. Raise your hand if you've come to work with a fever. You know, most of us have. Raise your hand if you've come to work nauseated. Raise your hand if you've come to work with a migraine headache. Sick days are discouraged. Starting in residency, what a burden it is for us to take time off, to take care of ourselves. There is woefully inadequate time given for rest or respite from physical ailments, much less mental ones. As I mentioned, the several days before he died, Blake had what I called a man cold. It wasn't COVID according to the at-home test, so he soldiered on working, likely with a fever, but of course he didn't take his temperature. And on the day before his death, he operated. I encouraged him to take the day off to rest, but he didn't want to inconvenience his patient and his patient's family to reschedule. And as I mentioned, he had a complication. Again, it wasn't mortal, but it was morbid. And he no doubt blamed himself for that complication. And he no doubt blamed himself for the decision to operate when he didn't feel his best. And I don't think he knew how to ask for help. It surely wasn't a habit he was practiced in. He needed help with notes. A scribe would have done him wonders. He needed help with his mental health, with setting boundaries, managing his workload. But to ask for help would have meant admitting that he wasn't okay, that he wasn't on top of it all, that he couldn't handle it, that the responsibilities that he continued to pile on were too great. He didn't want to let anyone down. And I think he thought of asking for help as a failure, when the reality is that asking for help is asking for connection, it's asking for support and partnership. It's the most vulnerable thing that we can do. So, we've identified the problems, we've identified the barriers. What do we need? How do we fix this? I'm gonna start with what we don't need. We don't need emails of empty words on Doctor's Day. We don't need crappy gifts. We don't need mandatory wellness CME, yet here we are. And we don't need resiliency training. That pisses me off more than anything. Telling physicians to become more resilient is bananas. We are the most resilient group of folks you're ever going to meet. You don't get to where we are without grit and without resiliency. And what we need is not that. We need the opposite of that. We need boundaries. We need to start seeing ourselves as equally important to our work. We need to remember that we have value, not because of the things that we do, but because we exist, and that's enough. We need to be able to dial back the idea that we have to do it all and be it all for everyone. That mentality is unsustainable. We need hobbies, not spending time with your children. That's parenting, that's not a hobby. But finding something that really fills us up, makes us happy. And most importantly, I believe we all need a therapist. So let's talk about therapy. As I mentioned before, I was burned out at the tail end of COVID. The world was falling apart. Politics is divisive. I come from a very different, I experienced life in a very different background from which I was raised. And I actually went to therapy because of my mom. I went to therapy to help to um, find a way to have a relationship with my mother, who believes in a very different world than I believe in. So I started seeing my therapist about a year before Blake died. And um, while I was there for a specific reason, she very quickly sussed out that I was in complete burnout at work. I was completely overwhelmed with the burden of the majority of um, primary housework and child rearing. And so I started to work on that. And as I started finding freedom and drawing boundaries and getting taking a day off and finding time, I encouraged Blake to do the same, but to no avail. And of course, after Blake died, my therapist became a literal lifeline for me. Um, it turns out that my therapist is actually a trauma therapist by training, and that turned out to be incredibly fortuitous. I went through the process of EMDR therapy to process the day of Blake's death. If anyone here has had what we call a capital T trauma, and if you haven't encountered that professionally yet, you will. I can't recommend this modality enough. What EMDR does is it reprocesses your traumatic memories until it no longer causes a physiologic reaction in your bodies. When I find out how Blake died, I was sitting in our surgeon's lounge getting ready to scrub in and help a partner with a hysterectomy. When I got back to work, it was months before I could walk back into that room. The physical act of just walking up to the door made me want to vomit. I was just so scared of what would be on the other side. Only through EMDR could I convince my body that something horrible wasn't going to happen if I walked back into that room. And I think back now onto my professional life and how helpful this modality would have been to help me recover from my professional traumas. The most traumatic event of my professional career to date was I was doing a repeat term C-section back when I practiced obstetrics in Oklahoma. And she had an amniotic fluid embolus as I was closing her uterus. First time I've done CPR since my ICU rotation in residency. She lived, amazingly. This was right when the AOK protocol was being published, and she lived, and she's alive today, as is her baby. But every C-section I did for the next 6 months, my hands would shake. My heart rate was probably 130. I couldn't convince myself that it wasn't going to happen again to every patient who I operated on. EMDR would have been magically helpful in getting the fear out of my body for every coming C-section. I am also a huge fan of internal family systems. If you haven't heard of IFS, go look it up. It is incredibly fascinating, and the world and the people in it have never made so much sense to me as when I consider everything through the lens of internal family systems. If you've seen the movie Inside Out 1 or 2, They're great movies. If you haven't seen them, you definitely should. But that's a wonderful primer on internal family systems. Internal family systems, the concept is we are all made up of these parts. And in the movie, Riley has her disgust and her sadness and her joy. And basically, we all have those parts inside of us. IFS breaks these down into kind of categories of parts. So we have our managers. I guarantee as physicians, all of us have an excellent manager part. This is the part that gets shit done. We are productive. We are competent, we plan, we caretake, this is what makes our world go around. And then we have our firefighters. These parts are the emergency responders. They swoop in when our system is overwhelmed. Um, this is substance abuse. This is binge eating. This is dissociation. This is self-harm and suicidal thoughts. And then we have our exiles. These are really usually like young parts that were kind of formed when we were kids. This is our fear, our shame, our trauma. We shut those down, right? They are uncomfortable feelings, and we exile those away so that they don't overwhelm our system. What IFS does is it teaches you how to embrace your parts and not stuff them away. It allows those exiles to come to the light. It tells those firefighters that we're going to be okay. And so when we think about hopelessness, right, one of the main risk factors of suicide, hopelessness is an exile. And suicidality, that's its firefighter. So if we can put hopelessness, that just a part of us, right, can't see the hope, our other parts can probably tell it where it is. It can help us find it. And so if we can start to recognize any given feeling we have as just coming from a part of us, that not all of us feels that way, that we're more than that one feeling or part, then we can start to heal those parts. We can start to let them not overtake us. IFS has allowed me to reframe how I feel and thought about Blake's death. It wasn't all of him that thought dying was the best option that day, only part of him. And IFS has allowed me a way to understand that at the moment of his death, that part had just drowned out every other part that might have reminded him of the millions of reasons he should stay. If he had practice in meeting uncomfortable emotions instead of stuffing them down, exiling them out, he might have been able to recognize his suicidality as a firefighter part. It was responding to shame, to fear, to pain. If he could have had the practice of being able to hear it out and tell it the things it needed to hear to be less lonely, to be less afraid, to be less ashamed, and to find some hope, he might still be alive today. So when I do this in a group in person, I usually kind of lead everybody through a little exercise of IFS. If you all are like me on a virtual meeting, many of you are probably in your car, and this takes closing your eyes. So we are going to skip this part today. But again, I'm just going to recommend everybody investigate IFS. There's a book called No Bad Parts, which is a phenomenal way to familiarize yourself with this concept. So we're gonna skip the exercise and but please go check that out. I will put up here some therapy resources, however. Psychology.com is a resource that I use almost daily in my clinic and give out to patients. So this is basically just like a yellow pages for mental health professionals, but you can go in, you can search by your zip code, your insurance, what kind of therapist you're looking for, if you want in person, if you want virtual, and it will just spit out a list of therapists in your area, and this is nationwide. BetterHelp and Talkspace are two of the many online therapy platforms that are out there. And for busy physicians, I know that it's hard to find that time, but I'll tell you, most therapists have evening hours, weekend hours. Like these are people who a lot of times work with busy professionals. I know Petra mentioned at the beginning, she's a coach, and there's a lot of people who are getting into the space of physician coaching. This is a wonderful resource for people who can talk to somebody who really truly gets it and understands. And so definitely encourage you to check out those resources if you need it. So, in addition to therapy, I said we all need hobbies. Oops. Um, we all need hobbies. We need things to do. We need things that fill our cup without the meaningless dopamine hits of things like doom scrolling, a glass or more of wine, and binge watching TV. Now, please note, I'm not saying never do these things. Ted Lasso is coming back for another season after all. But finding some way to get exercise, to get sunshine, to get vitamin D, touch grass, as the kids like to say, use your creative energy and connect with friends. These are data-driven ways to improve our mental health. The hardest and most important part of a hobby, however, is creating the time for it. And as physicians, this is just something that you have to do really, really intentionally. Um, Up in the top left corner, that's me and my partners. We all started playing mahjong, and that's been super fun. I took piano lessons up again. My youngest takes piano, and I started taking along with him, and it's been so fun to find that creative outlet for myself. And then my two babies are right there in the middle of the screen. That's Rico and Kowalski, and walking them every day is you can tell that the number of walks my dog gets are directly related to my mental health. And you can tell when I'm like, I'm gonna go walk the dogs, my kids are like, oh, go ahead. Like mom needs to pound the pavement and think it out. So find something that allows you to connect with um, with yourself and with nature. Connection. We saw earlier that a lack of support system is a risk factor for suicide. Connection and community are the antidote. Now, I'm going to make some generalizations, but bear with me. So, as an OBGYN trained by mostly female faculty, I was sat down on July 1st of 2005 by our program director, and I was told, never go down alone. I knew at any moment in time in my training that I could ask for help up the chain of command, and it would be met with support in an educational manner most of the time. I don't think that mentality was broadly preached to all surgical specialties, especially those under the leadership of men whose beliefs were rooted in hierarchy and perhaps the thought that a certain kind of suffering makes stronger and better surgeons. That mentality of teamwork and support has followed me through my two amazing practices since I left training. I've always had wonderful and collaborative relationships with my partners. We operate together, we take care of each other literally and physically. We cover each other to allow attendance at school plays, awards assemblies. In short, we ask each other for help in little ways and big ways every single day. And Blake didn't have that relationship, really, despite him trying to nurture it with his colleagues. The most powerful form of connection is asking for help. When people ask me how I've managed to live life after Blake's death, it's only with help that I've been able to make it. My kids have been my literal reason to get out of bed every day. But for the first time in my life, I couldn't do everything I needed to do on my own. I had to have help. I lacked the capacity to do so much because grief overwhelmed my every thought. I've been surrounded by women who have stepped in and done the things I couldn't do, and then continued to offer support once I could start to do them again. They've allowed me to be the mess that I often was and have been, and have never asked me to be okay when I wasn't okay. My amazing support system has been led by my rock star sister, my amazing mother-in-law, and the best friends and partners on this earth. I've managed to carry on because they've been there with me every single step of the way. So as we come to our close, I hope you can all see that we need a revolution. We have to start prioritizing our physical health, our mental health, and our time. We must stop glamorizing workaholic habits and martyring ourselves to our careers. Medicine is a passion, yes, but not one that should consume every minute of our time and every bit of ourselves. We need to shift the culture to promoting our own well-being while maintaining our goal of optimizing that of our patients. To steal some airline terminology, we've got to start putting our own oxygen masks on first. But this has to be more than one more thing for us to do in order to save ourselves. It's not just you and I that we have to convince. We have to make the decision makers, the employers, the program directors, our hospital and practice administrators and licensing board, we have to take them to task. We must start demanding being treated like human beings. I don't know the answer. I don't know where to start, honestly, other than doing this. So I'm telling my story. I'm telling Blake's story and hoping that at least one person in each room where I speak hears it, recognizes himself in it, and gets the help that they need to change their life for the better. And I hope we can all start figuring out this process for ourselves, our colleagues, and our future. If anyone on this meeting has contemplated suicide, I need you to know a few things. Number one, I'm so glad you're here. So many people are so glad you're here. Please remember always that that feeling is temporary. And lastly, remember it's only a part of you that felt that way. You're bigger than that part, and you need to realize that sometimes that part is very loud. And you can figure out how to tell it the things that it needs to hear and make it know that it's okay and not to be so scared. It can be at peace. If you are considering suicide, the National Suicide Hotline is 988. Please dial that number if you need it. And for the rest of you, I hope if you have concerns about a colleague, you'll go to them with support and care. Many people who worked with Blake saw a change in him in the weeks prior to his death. Everyone thought he'd get over it. He was stressed out. He was overworked. So, to borrow one more TSA phrase, if you see something, say something. You never know if you might be a lifesaver for someone who might not even know that they need it. And that's it. Thank you very much. Happy to answer any questions if there's any.
Andrea, I'm just overwhelmed, and I just want to say thank you for this incredible gift of you sharing your story and for what you're doing. I'm happy to sign up to be part of your revolution. Um,
We ride at dawn. No.
yeah, I think I also just want to remind people that Tara and I are here as wellness directors. I'm a mental health first aider. We're always here to talk and support you. And just, I can't say thank you enough for bringing this forward and sharing your story. Thank you so much.
I think I saw someone in the chat talk about the book The Body Keeps Score in relationship to EMDR, and encourage everybody to read that as well. It is a fascinating read, and really talks about literally how trauma is stored in our body, and makes sense why EMDR is so helpful once you kind of understand the physiology of it. So that's an excellent resource as well.
And yeah, and speaking of sort of trauma and dissociating, et cetera, Tara was able to get a grant together to partner with Dancy Perinatal, which I'm not sure if you're familiar with them, but it's someone who was a therapist and was helping women who are going through sort of perinatal trauma. And she recognized that the staff involved in the deliveries were also traumatized. And so now it's sort of a support service where they have very specific therapy, which I think EMDR may be part of what they do, for 6 sessions when there's a traumatic event that you can sign up for, to work through that so that it doesn't, stay with you. It doesn't affect you long term. And
Yeah.
so we have that resource available now.
Yeah. It is I love hearing about programs like that. And it is our entire staff, right? Everybody in the room is affected when we have a traumatic event. The nurse who was with me in the case of my amniotic fluid embolus that I spoke about earlier, she literally wouldn't she wouldn't take care of one of my C-section patients for months. She's like, it's bad luck. We're not doing it.
Mhm.
and just, the impact that those things have, down the line to everyone in the room. It's really can be profound for sure.
Dr. Palmer, thank you so much. I'm Tara, the other wellness coach.
Yeah.
Um, Thank you for sharing such a personal story and sharing with others what you've gone through and what you've learned from it. I can only imagine what that process was like to get to being able to present in front of people.
Lots of
Um,
therapy.
and I appreciate how you shared some like tangible things that people can do to help themselves instead of like a gift on Doctor's Day or whatnot. And asking for like institutional support to make changes so that doctors can feel supported, I think is really important. And I just want to remind the residents as well that they have access to Tend Health through GME that has weekend and night hours. And that's a covered benefit because it does often feel like we don't have time. So whether you're a resident or attending, it feels like there's no time for this, but it is important to make time for yourself and caring for yourself in whatever way it is, because everyone's different. And maybe some people that wouldn't feel like the right fit, but um, and this is also very heavy. So I know some people might need some time to like debrief or take a moment afterwards. Definitely understand that. So if you need time today, folks, take that time.
For sure.
And I'm just glad that everyone has joined. So many people have joined, and I'm
Thank
getting
you.
texts from
Thanks,
people
everyone.
that this is really impactful and that they appreciated it. So thank you so much.
Yeah. Yeah. Thank you all again.
Yeah, I wanted to mention one last thing that you said, which really struck me, is the lack of boundaries. And I've been sort of, trying to figure out, what is the approach we need to take. And I have been noticing that physicians don't have boundaries, um, and that the system works under the premise that they don't have boundaries.
Right.
So now that I'm older, I feel like I have nothing to lose, and I've been in a very low place before, and having the therapy to get myself out of that low place. I recognize I have nothing to lose, and so I'm encouraging myself and others to place boundaries, because if we don't ask for them, we won't get them.
Right.
So it's
Because if
really
we have, I mean, the system thrives on our inability to say no.
exactly,
It,
exactly.
it preys on our dedication to our patients and our dedication to our craft and our desire to do good and to help people. Um,
Right.
and so they're not going to do it for us. Um,
No,
it's
no.
something that we have to learn how to do ourselves. And if we can start having these conversations with residents, right? Like, let's have these conversations with medical students. Let's teach people early on that their worth is um, in more than their service,
Yeah.
and it's it's going to have to change from the ground up.
And I think, in a sense, it has, because I think we've talked about this recently, that the younger generation is more aware of the need for balance and
Mhm.
is more willing to speak up for it. So I feel like I've also been learning from my learners.
Yeah,
So I think we can help each other.
yeah.
Definitely.
I sat on I joined our core faculty this year, as you mentioned, and I sat in on a few resident and participated in some resident interviews. And I had like more than one resident ask me what we do for psychological safety at our program. And I loved that question coming from them. And I just thought back, like, what
Right.
would they have said to me if I would have asked that question
Yeah.
as a resident? It would have been, I mean, and I went to like a fairly, a non-benign program. I went to, again, a really supportive program. But I think if I would have asked that question in residency interviews as a medical student, they
Like,
would have looked at me like, what the fuck are you talking about?
mhm, mhm.
So I do think, again, I think it's changing. I think this is, um, I think that the revolution is in process, but I think that it is going to have to be believed by the people at the top in order to make it any kind of sustainable change.
Dr. Palmer, along that line, Dr. Hamblin asks, can you discuss some institutional supports for physician wellness? You mentioned chart closure as a major pain point. What have you seen as examples of supports?
Right. So I and every institution's a little bit different. I think any kind of help that you can take from, either a remote scribe or an in-person scribe, AI, like the ambient listening stuff, I think that that is going to be really revolutionary in helping. Um, and so I think that things like that can definitely be an aid. I do think that taking time to work within your system and sit down with one of, like, the tech people that they have that support you, like sit down with those people, make your templates, like make typing less of a thing and make clicking and inserting, like try to set yourself up for success as much as we can in those veins. Like we're not getting away from Epic, we're not getting away from EMR. And so really you just have to like lean in and accept it and try to make it the best that you can. But if there's an opportunity to have help through a virtual scribe or in-person scribe or use something like AI, I think that can really be helpful as far as just the burden of charting. Um, I do, I don't have a scribe or any of those things, and I do a lot of charting in my room. I do a lot of typing and looking like this and talking. Um, but my husband never took a computer into the room. That was like the hill literally that he died on, of like he was going to engage and be present with his patients, and that's why he was so beloved, and that's why his clinic was always behind because he spent so much time with people. But literally he walked out of clinic with 0 notes done every single day. And we have to get over the fact that, again, like that perception of I'm only good if I can do this. We have to, like, our patients need to know that we're human. And if I have a patient who complains about me charting in the room, I just tell them, I, you know, I have a lot to do. And if I don't sit here and type it, I'm going to walk out and forget it. So if you want your note to be accurate and reflect what we just talked about, you're going to have to give me a minute to like sit here and do the thing. And so I think that, handling patient expectations of our kind of engagement and interaction and B plus charting. I am all here for that. Like I don't spell correct. I don't complete sentence. I type enter, type enter, type enter. It's just lines of text, but I know what happened and the point gets across. So I think, rectifying that in your mind is one thing. From a facility standpoint or from an organization standpoint, I think that um, the list of requirements of the things that we have to do is just ever increasing. The learning modules about this and the OSHA module about that. And I understand I'm part of our hospital leadership. And so like, I understand the necessity and importance of like having this stuff done. But on the flip side, as somebody who has to sit around, turn around and do it myself, it's just that death by a thousand cuts, the little, another thing that you have to do, another thing that you have to do. And I don't know how we get rid of those. I don't know how we convince, you know, the institutions that and I don't know what the better way is, but I think it all needs to be part of the conversation.
Yeah, our former CXO that I was telling you about had something called GROSS, GROSS. It was an email that you could send, and it was get rid of stupid stuff. So if you noticed something like that, that was just mindless and taking your time to
Yeah,
forward it to that email, and then they would try to take it up the chain in the C-suite essentially to see how it
yeah,
could be addressed. And then in terms of the documentation, I don't know where we stand as an institution, but this would be good for us to find out, is using DAX, which is the AI tool on your phone,
mhm,
where it listens in on your conversation, creates a note for you. And I think it's right now, I think it's being piloted. I don't know. That's something that we could look into more, but I think Dr. Manning is sort of leading in that. So we can ask him some more information about that because um, that's potentially a tool that would be really helpful.
yeah, for sure.
Well, wonderful. Again, thank you so much for spending your morning with us.
You're welcome. Thank
And
you all again for having me. And I love that you guys have this initiative at your institution, and keep doing the good work and let me know if I can ever help.